In looking at JAMA Insights, the clinical update published April 24th, 2020, the title is Management of COVID-19 Respiratory Distress by John J. Marini, MD, and Luciano Gattinoni, MD. So I'll kind of just cite what was said in the abstract of this article. So ARDS, it can either originate from gas or the vascular side of the alveoli. Although the portal for coronavirus is obviously inhalation, the alveolar infiltrates are commonly found on chest x-rays or on CT scan. The respiratory distress appears to include an important vascular insult that potentially mandates a different treatment approach that customarily applied for ARDS. Indeed, the wide variation of mortality rates across the different intensive care units raises a possibility that we are possibly not really managing ventilatory-wise, meaning it's perhaps not the right approach. So COVID-19, it's a systemic disease that primarily injures the vascular endothelium. We often hear the cytokine release syndrome or the cytokine storm. If not expertly individually managed, with consideration of the vasocentric features, a COVID-19 patient with ARDS can eventually develop multi-organ failure, even when not of advanced age or predisposed to pre-existing comorbidities. So let's just look at ARDS normally, how we're used to it and how we manage it. So normally ARDS is characterized by the non-cardiogenic pulmonary edema, the shunt-related hypoxemia, and obviously the reduced aeration and lung size, that we often hear baby lung, which accounts for the low respiratory compliance. In such settings, increasing the lung size by recruiting previously collapsed lung units is often achieved through the use of high levels of positive and expiratory PEEP and recruitment maneuver and prone positions. But basically, a high transpulmonary pressure induces stress across the lung that is poorly tolerated in ARDS. So relatively low tidal volumes, together with the tolerance for moderate permissive hypercapnia, to facilitate the goal of minimizing alveolar-induced lung injury. Indeed, the early phase of ARDS, before the patients have fatigued or been sedated, the high transpulmonary pressure they're associated with spontaneous, rigorous inspiratory effort, and that can actually cause self-induced lung injury. And just before, I don't want to jump right away, I want to just mention, this is something though that we see in COVID patients, this extremely high respiratory drive, and I'm sure that the same applies for the transpulmonary pressures that can actually, just with their own inspiratory effort, create self-induced lung injury. That's why when we look at the two phenotypes, and we're going to talk further about that soon, but most of them come with basically good aerated lung, good compliance. Perhaps there's a smaller group that are beginning to create self-induced lung injury because of their work of breathing. So soon after the onset of respiratory distress from the COVID patients, they initially retain relatively good compliance despite very poor oxygenation, and the minimum ventilation is characteristically high, right? So the infiltrates are often limited to in extent initially, as usually characterized by the classic ground glass pattern on the CT scan that signifies that there's interstitial rather than the alveolar edema. So the edema isn't necessarily in the alveolus. So many patients do not even appear to be overtly dyspneic. These patients can be assigned in a simple model, and this is what we call the type L, right? That's characterized by low lung elastance, very compliant lungs, lower lung weight are estimated by the CT scan, and the low response to PEEP. For many patients, the disease may stabilize at this stage without any further deterioration, either because the disease severity and the host's response or suboptimal management, right? May transition to a clinical picture more characteristic. So they may start with the type L, but because of either self-induced lung injury from work or breathing, that might possibly because happen if we delay intubation. But if we don't have a consistent individualization, in my opinion, of mechanical ventilation and a quick way of referencing whether they are type L and type H. Keep in mind that as a respiratory therapist at the bedside, the classic high respiratory drive, these minute ventilations often we're seeing 15 to 17, makes it actually quite difficult to do pulmonary mechanics consistently, where if we're using global values on the ventilator, that's kind of like just looking at the top of an iceberg, and we're really not going underwater to see how big the iceberg is underneath in a way. So when you're looking, we need to find a way to quickly define which phenotype they are, and also to trend and see immediately if they're transitioning to a type H, traditional ARDS, or God forbid, unfortunately what we see is a combined, right, type L and type H. So you got the type L with usually good distribution of ventilation, uniform distribution of ventilation, lung mechanics are maintained, but we have the D-dimers that are going up. We've already got knowledge now about the microembolisms, the clotting that happens. So basically we're looking at ventilation that's available, but the capillaries aren't picking it up. It's dead space ventilation. And if we're going to be trying to add positive pressure to a well-ventilated lung, we're not fixing, obviously, the vascular issue in the lung, and we are not going to do anything probably good by intubating. So let's just continue a little bit here, reading the rest of the article. So these can be defined as type H and extensive CT consolidations, low compliance, higher lung weight from the edema, and high PEEP response. So clearly type L and H are the conceptual extremes of a spectrum that includes intermediary stages in which its characteristic may overlap, and that's kind of what I mentioned. That's really what we're seeing clinically. Often they are more the type L, but when we start intubating, we definitely, if we're not all on this, if we're not all on the same page, we're going to have a combined, type L and H somewhere along that spectrum. So you're in a really bad position if initially you had good aeration, especially most importantly to the mid-dorsal and dorsal regions, and perhaps they're hypoxic, but the distribution is good. So common sense, we're saying that it's probably vascular. Now, if we had good dorsal distribution of ventilation, and now we're not determining phenotypes, and we start increasing PEEPs, and we're not doing proper PEEP studies, and which is quite hard with these quick minute ventilations. We're gonna intubate these patients, and then after we're actually going to destroy potentially or reduce the dorsal and mid-dorsal distribution to the gravity dependent areas, and now you have a complete VQ derangement, and we know what happens. These observations, they indicate the fundamental role played by disproportionate endothelial damage, and it disrupts the vasoregulation. It promotes ventilation to perfusion mismatch, the primary cause of initial hypoxemia, as I mentioned, and this fosters the thrombogenesis. You're developing all of these thrombi. In addition, In addition, remarkably increased respiratory drive may, if unchecked, intensify tidal strains and energy loads from patients' respiratory effort applied to high vulnerable tissue. All right. So now we're adding to the mix all of these inflammatory assaults on top of it. So when confronting such an unfamiliar and rapidly evolving environment, only certain aspects of the well-accepted lung protective approaches to ARDS remain rational at these different stages. More important inattention to the vascular side or avoidance of fluid overload reduction. So let's look at so far what we've been looking at in relation to trying to, again, just like we at one point figured out traditional ARDS, and how to at least be as protective as possible. Hopefully we're going to figure out with COVID-ARDS. Now, I believe that I have a very quick and safe and on top of it, at the bedside way of quickly identifying which phenotype we are presented with in the intensive care unit. We can do a baseline to define this phenotype. We can assess the distribution of ventilation across the ventral, mid-dorsal, as well as dorsal regions, looking at obviously mid-dorsal to dorsal regions as the most important areas to not be deranged or abnormal. So let's just see what JAMA Network has said so far. So patients with type L COVID-ARDS have good compliance. They accept larger tidal volumes than those customary prescribed with ARDS without worsening the risk of ventilatory injury. So in a 70-kilogram man, the respiratory system compliance is 50, let's say. The PEEP's 10, the tidal volume is 8 cc's per kilogram of ideal body weight, and it yields, let's say, a plateau of 21 and a drive pressure of 11, both well below, currently accepted thresholds for, thinking that we're causing any ventilatory-induced lung injury. So the higher tidal volumes could help avoid reabsorption atelectasis and hypercapnia due to hypoventilation with lower tidal volumes. Once we're done, I believe that I have a way of solving any possible reabsorption atelectasis, as well as using lower tidal volumes. And I can speak about that in another video. The key issue in this early stage is disrupted vasoregulation, where the pulmonary vasoconstriction that normally occurs in response to hypoxic fails to occur because of the endothelial assault that mismatches the ventilation to perfusion. Okay, I don't think we have to go much further to understand that there are two phenotypes, and that we must be able to trend and immediately ascertain what type they are. We need to trend. Obviously, as mentioned, there's a spectrum. We need to trend the distribution of ventilation, especially to the gravity-dependent areas. Now, we can take a CT scan using radiation to take a picture to see possibly what phenotype. Again, global values on the ventilator does give us some feedback information. However, I believe that electrical impedance tomography, the first generation electrical impedance tomography, is the Pulmovista from the Draeger company. It's a simple 16 electrodes that are strapped on a belt, a rubber belt, put across the patient's chest. And using electrical impedance, the computer is able to tomographize a caudal to cranial view of the distribution of ventilation over the ventral, mid-dorsal, and dorsal regions immediately without any radiation, and pretty much no need to move the patient anywhere. It's done at the bedside, and the movement of the patient is as much as what we would do for a AP chest x-ray. We put this strap, and within about 5 to 10 minutes at the bedside, we can ascertain the regional distribution of volume for each breath over the 4 regions of interest: ventral, down, right down to dorsal. This will quickly be able, the clinicians and the critical care team, to right away have a baseline phenotype. Often they're put on a high flow nasal cannula, and the trending can continue using this simple electrical impedance tomography. If a patient is intubated, and we can further look at the possible transition into the type H, and we can catch that far ahead. Now, I also have a ventilatory mode that I believe is the most protective and most versatile for basically handling COVIDs with deranged and abnormal diffusion capacities. And at least this mode can possibly, using time, be adapted into a more diffusion. We have to understand that every time we are moving the lung, it is possible that we are hurting them, because we know that all forms of ventilation are quite abnormal ways for the lung to be functioning. We don't really blow the lung up like a balloon. So, like I said, the Pulmovista uses electrical impedance tomography, which is quite simple. You have 16 electrodes that go around a belt around the chest, and they send vectors across. So these action potentials are impeded differently. There's a lot of impedance through air, there's less impedance through collapsed lung tissue, and less impedance with water, with fluid. Obviously, electrical current just loves to go through water and has a harder time through it. So these vectors that are sending about 50 vectors per second are able to use tomographical computerized information and give a image of the distribution of ventilation. When looking at the electrical impedance tomography, the Pulmovista, we are looking at a caudal to cranial view similar to CT scan. We are able to quickly look at the distribution of ventilation, and we're able to see if it is a type L. If it's a type L, they'll be admitted and they'll have good normal distribution of ventilation over the ventral, mid-dorsal, and dorsal regions. We want to really concentrate probably at the gravity-dependent regions, so we're going to be concentrating more on the mid-dorsal to mid-ventral, unless we're proning, and then the ventral and mid-ventral would become the gravity-dependent regions. The most important is that we have to realize that if the ARDS, the COVID ARDS patient is presenting itself with the classical vascular damage, if they have good distribution of ventilation, a normal type L phenotype, and they're hypoxic and the D-dimers are high, it's obviously a very clear sign that a significant portion of this patient's refractory hypoxemia is due to perfusion and not ventilation. The poor outcomes, at this point we understand that we're intubating the type Ls that are properly aerated, and the PEEPs are often very low. However, the refractory hypoxemia, often we are tempted to increase the PEEP. Again, it's very difficult for a respiratory therapist to sometimes do the pulmonary mechanics when the classical high respiratory drive are causing very difficult to do plateaus and pauses and expiratory pauses. And we can't just be setting these people on rock drips. I mean, this is, as everyone knows, an extremely long pathophysiology. This is not cleared up like a classical ARDS in sometimes as quick as 7 to 10 days. Okay, so it's so the tomography machine is able to right away ascertain the phenotype. We are going to be able to trend, and we're able to obviously do optimal PEEPs with it. We're able to see compliance on the high part of the pressure volume loop as well as the low part, and this is all done at the bedside without moving these hypoxic patients. So my suggestion is that we use this tomography machine as a baseline on admission. Often, again, they're on OptiFlow. Baseline, let's get the phenotype. Depending on our manpower, the more tomographies, obviously, the more data, the more trending. But I definitely would like to suggest for our intensive care unit for now, that immediately we have a baseline tomography, followed by any increase in oxygenations, any increase in work of breathing, any drastic reduction in the ROX index, that another tomography would be applied. If the patient obviously is intubated, another, using the Pulmovista, another tomography and a PEEP study. Whenever there's significant changes requiring significant changes in mode or pressure levels or anything ventilatory power, any real clinical state that might suggest that there's something different happening inside the lung, another tomography can be applied. We need to, we're not serving any good purpose saying, yay, we figured out which phenotype it is, and we're not even really diagnosing it. We can't be sending people to CT scans and radiating them, every few days. The ROC index basically is, as you know, the SpO2 over FiO2, and then divide that by the respiratory rate. It's been adopted by Fisher-Paykel on their site. Here is the app that is quite useful. The issue, though, is that this is looking at globally. Obviously, somebody who has a low SpO2, has a high FiO2, and is breathing fast, the ROC index will, indicate that we should consider intubation. I guess the cutoff is 4.88 under there, and as it trends lower and lower on OptiFlow specifically, this is a great index, a quick, little measurement to add to your clinical action plan. However, it's incomplete, especially in COVID patients, because COVID patients, the direction of therapy should be based on the phenotype, and the ROX index cannot really give us the phenotype. So I definitely think that it should be used, but it also should be modified. We need to add to the ROX index the dorsal and mid-dorsal regions. So what I'm trying to say is if you have a ROX index that is below 4.8, okay, and now you do a tomography and you see that the patient has quite abnormal and poor distribution of ventilation to the mid-dorsal and dorsal regions, now you have a patient who potentially has very poor perfusion as well as very poor ventilation. Now, this is a patient, my hypothesis is that this is a patient at least that may have a high probability of being intubated, and that it would be beneficial because they have poor distribution to the commonly atelectic areas of mid-dorsal to dorsal regions. We have a ROX index that's verging, close to being suggesting for intubation, the 4.8, starting to be below. But we look at the regional distribution with our tomography machine, and we see that the mid-dorsal and dorsal regions are excellent. They're within normal limits. Then that should be something that the intensivist is able to get that information. And as a respiratory therapist, we have that capacity to help the critical care team in this important, we're in a pandemic. This is all new. The respiratory therapist can really step up during the pandemic with the use of a simple monitor, using no radiation. We can use it as much as we want, and there's really no con to the situation. I can only see pros. Now, if you have a ROX index and it looks like the patient's not doing too good on the ROX, maybe it's a 2.5 even, or 3. If we look at the mid-dorsal and dorsal regions, and that individual has great distribution of ventilation, then that needs to be taken into account. So my suggestion is, and if you look over here on the Pulmovista, you can see the ventral down to the dorsal, and you can notice that the dorsal is 8 to 15, and the mid-dorsal is 35 to 40. right? So if you have a patient failing the ROX, you better be darn sure that your patient has a normal dorsal and mid-dorsal, because if they have poor ROX, indicating poor perfusion, as well as no distribution in a gravity-dependent area, that's telling us, hey, he might have a good, the person might have a good outcome for intubation, because there's a complete VQ mismatch. But if we know that there's good distribution, that's important for the doctor to know. I hear nothing about the tomography. The whole COVID pandemic needs to be tomographied. Okay, it is made. It is literally made for this pandemic, and it needs ASAP to become one of the top monitoring devices to help our sick patient population. Just one moment, I just need to press pause. Okay, sorry about that. So like I said, when you look at the mid-dorsal, it's 35 to 45. So we write 35 to 45 for the mid-dorsal. Then we'll look at the dorsal regions. And the electrical impedance tomography says that the normal dorsal region is 8 to 15. Okay, so let's not discount the ROC index. Let's keep the ROC index. Okay, so ROC index, and it's important here that we know the 4.88 cutoff. Anything below the 4.88 ROX index, as it starts trending below, this is going to help us say possibly the high flow is not enough, and that we need to start considering possible intubation. Now, for the COVIDs, we have to use the ROC index, but we have to add some way in this index to determine the phenotype. So I think for now, it's a quite reasonable starting point to say that if my patient's hypoxic and failing the ROX, I hope that my patient at least has the lower level normal of the mid-dorsal region and the low level normal of the dorsal region. So like I said, mid-dorsal is 35 to 45, and dorsal is 8 to 15. Okay, so let's add to the ROC. I would say that if I'm failing the ROC, the patient needs to at least have the lowest level of normal. So the 35, so we want to keep an index very small, the number. So the 35 becomes 3.5, and the 8, which is the lower level, becomes 0.8. And when I'm talking about 35 to 45, I'm talking about the percentage. So each volume, okay, what percentage is going where regionally, and we can look at quadrants, we can look at different layers. We can divide it as we want, but for this pathophysiology, we're going to look at ventral, mid, and then the dorsal. So what we should add to it is I call it the T-ROX, which is the tomographied ROX index, so it's the ROX, but also adding the tomography and the information of the distribution of ventilation, which in this index will be able to determine and trend what phenotype all along the spectrum visually and with actual numbers. So I'm adding 3.5 and 0.8, which is the minimal normal. So that means that 4.8 is the cutoff for the ROX aspect, and the T-ROX would be the minimal normal. So that ends up being 9.13. Okay, so what I'm saying is when we take the ROX index, we use the tomography, and we say to ourselves, if the ROX is out of whack and it's probably a perfusion, then let's look at the T-ROX, and let's visually have eyes inside the lung and look at the mid-dorsal to dorsal region. And if it's anywhere below the lowest level of normal, now we have eyes inside the lung, and the intensivist has a very important information. we're basically saying that this patient, if it's 9.13, they have abnormal mid-dorsal to dorsal as well as possibly perfusion. So below 9.13 is a quick hypothesis to start looking at the T-ROX index. How are we going to find out the true cutoff for T-ROX? Is obviously we're going to have to collect all of the tomography results. We have it visually and on the printout of the Pulmovista. We also have the percentages of regional distribution. 1 second. All right, so seems like, sorry if I'm repeating myself. So basically, T-ROX, if we're adding the 3.5 and 0.8, which is the lowest level of normal, if you're below 9.13, it might be an indication that your patient has significant perfusion as well as ventilation mismatching, which if you're below 9.13, if you're completely mismatched with your ventilation and perfusion, and now ventilation is actually abnormal, I think that if we use this index, then it's going to help us guide and have confidence to know when to intubate. When you're below 9.13, it means that you potentially have poor ventilation as well as perfusion. And there's no guessing, because the RT can do this within 10 minutes and print out the report for the doctor and tell him the patient is below 9.13, he's borderline, and as it keeps on descending, 8, 7, 6, then we understand that they're worsening, and each time the index is going lower and lower, then we can start having more and more confidence and not doubting ourselves that yes, probably this patient might need to be intubated. So the T-ROX index is good for patients that are not intubated yet, and it will also apply and help us guide and keep an eye on what phenotypes if unfortunately they do have to get intubated. So I'm speaking to you guys because I think that this is a great idea. I think it's a lot more accurate. I think that looking at the ROX index to guide us with the COVID patients, it's not that it's not good, it's just it's incomplete. It's like looking at the top of an iceberg and, let's say this is the water level, and you have like an iceberg that's sorry for the analogy, I hope it's a good analogy. So you got the water, you got this iceberg, and now like the boat doesn't want to hit it, so it's going like this and it sees it, so it starts avoiding it. This is the ROC index. You have no idea what's happening inside of the lung, you just see global values. But what if underneath the water the iceberg is this big? Now the boat will try and avoid by just going here and might not realize all that's going underneath the water. So the ROC index has its use, but when we start looking at the tomography, we have eyes inside the lung, and we know where the top of the iceberg is, the ROC index, the global value, the compliance that we see on the interface of the vent, and now the tomography, the Pulmovista, gives us eyes, how big that iceberg is under the water. You don't want to be like the Titanic, just avoiding the top of that iceberg, thinking you're safe by avoiding this aspect and totally creating a disaster. I think that the electrical impedance tomography is just that. We have eyes on top of the water, we have eyes underneath the water. So my analogy is that this gives us global values that are useful, and this will actually give us eyes inside the lung, breath per breath, in a dynamic fashion.